Hello and welcome everyone. In the previous video, we discussed about the pathophysiology and the technical aspects of pulmonary hypertension. In this, we will look at the more practical aspects, that is, the guidelines for diagnosis and treatment of pulmonary hypertension. This is the 2022 guidelines from the European Society. Since this is a very long guidelines, we will be dividing it into various parts. This is the part 1. This is being done so that it doesn't become too long a video. So this is the basic classification that we have. You have pulmonary hypertension, which is now defined as a mean pulmonary artery pressure more than 20. Previously it was 25, if you can remember from our last video. If you want to make it pre-capillary, it is similar, but you also associate it with a pulmonary arterial wedge pressure of less than 15 and a vascular resistance of more than 2. Next, you have the post-capillary, where the wedge pressure is more than 15 and the resistance is less than 2. Next, you have the unclassified, where you have the pulmonary artery wedge pressure more than 15, but you also have the vascular resistance, which is more than 2. Next, you have exercise, which is diagnosed during exercise, where the slope between rest and exercise shows a increase of more than 3 millimeter Hg per minute. So based on this, you have various classification. So it is classified into group 1, 2, 3, 4 and 5. Group 1 is pulmonary artery hypertension, which is mostly idiopathic. So in this idiopathic, you have two types of patients. One is a non-responder at vasoreactivity testing, and there is an acute responder at vasoreactivity testing. Then you have heritable drugs and toxins and associated with disorders like connective tissue, HIV, portal hypertension, congenital heart disease, pH with features of venous and capillary involvement, persistent pH of the newborn. So all this is classified as group 1. Group 2 is when the pulmonary hypertension is associated with left heart disease. It can be heart failure, valvular disease or any congenital anomaly. The third is pulmonary hypertension associated with lung disease or hypoxia. So this is the one which is associated with the lung conditions like emphysema, COPD, restrictive lung disease and other such situations. Next is pulmonary hypertension associated with pulmonary artery occlusions. So this is regarding chronic thromboembolic phenomena. Next, final group is pH with unclear or multifactorial mechanisms. So here you have multiple factors playing into this effect. So you have hematological disorders, you have systemic diseases like sarcoid, metabolic disorders like glycogen storage disorders, chronic kidney disease, tumor-related microangiopathy, fibrogen, mediastinitis, and all these type of things. So once we know the measurements and classification, next we go into the epidemiology. Pulmonary hypertension affects all age groups across the world. The prevalence is around 1% of the global population. Higher prevalence is seen in people over 65 years, mainly because of associated heart and lung disease. The most common causes being left heart disease, which is quite obvious. This is the global leader for this, followed by your lung disease like COPD. So these are the two most important conditions one must remember. Pulmonary hypertension worsens symptoms and increases mortality regardless of these underlying conditions. Now, in developing countries, important but less studied causes include congenital heart disease, infectious disease like schistosomiasis and HIV, and high altitude, that is, patients who have chronic hypoxia. So, if we go group wise, regarding the group 1, that is pulmonary arterial hypertension. The incidence is around 6 new cases per million adult per year. The prevalence is 48 to 55 cases per million adults. Traditionally, it is thought to affect the younger population, especially females. Currently, most cases are diagnosed in old age group, so the traditional teaching is slightly changing right now. Regarding the sex distribution, this affects female twice often as males, but overall the sex difference are decreasing with age. Most common subtypes are the idiopathic, where we do not find a cause, which is around 60%, linked with a connective tissue disorder, chronic heart disease, and portal hypertension is seen in other cases. Drugs and toxins are increasingly being recognized as risk factors because of drug abuse. Some have definitive association, like the use of appetite suppressants, while others there is a possible linkage. So these are the various drugs which have been associated with the development of pulmonary hypertension. So as you can see, there are a lot of drugs which are abused and they have a potential for causing pulmonary hypertension. So one must keep in mind these drugs if the patient is having them, to know that they can go on to develop this. Some common cancer drugs are also there, that also must be kept in mind. Next is group 2, the pulmonary hypertension with left heart disease. Heart failure is a common risk factor. Around 61 million people globally have this. More than 80% in developed countries are over the age of 65. Pulmonary hypertension in the preserved ejection fraction population is seen in at least 50% of these patients. Regarding valve disease, pulmonary hypertension occurs in up to 70% of the patients with severe mitral valve disease and up to 50% in symptomatic aortic stenosis. Well, basically all this thing will depend on how quickly the left atrium is getting affected and the ventricular function is getting compromised. So these are very common things with valve disorders. Next is pulmonary hypertension due to lung disease. Again, one of the most common things that we see. Mild cases are seen in advanced lung diseases like COPD. However, in severe COPD, up to 5% of the patients have a very high mean pulmonary artery pressure, which is more than even 35 to 40. So idiopathic pulmonary fibrosis, where the mean pulmonary artery pressure is more than 25, is seen in around 50% at diagnosis. The prevalence increases with the progression of the disease. With high altitude, that is around 120 million people who live at more than 2,500 meters above the sea level, and they are at risk of a chronic hypoxia and this thing called chronic mountain sickness. The exact burden in this population is not clear because there are very few studies which have looked into this. Next is chronic pulmonary artery occlusion. The thing that we are looking for is the thromboembolic phenomenon, that is chronic. The incidence is 2 to 6 cases in million adults per year. The prevalence is 26 to 38 cases per million. It is increasingly recognized due to the better screening of the patients with persistent symptoms after pulmonary embolism. Next, you have the unclear or the multifactorial cases. It includes a variety of diseases where PH has several causes, often both pre and post capillary, and direct vascular effects as well. The prevalence is not really well established except for very few conditions like sarcoidosis. Pulmonary hypertension in this condition is linked with increased illness and death. Now, how do we actually make a diagnosis of pulmonary hypertension? So the main goal is to have an early suspicion, that is recognize the possible pulmonary hypertension early and refer high risk patients quickly. This is very important. Identify the cause, try to find an underlying cause, because mostly it will be either heart or the lungs, and classify it for proper treatment. So the clinical presentation for most common symptoms is progressive breathlessness, that is dyspnea, especially on exertion. Other function symptoms are fatigue, chest pain, fainting with syncope, that is swelling of the limbs, and palpitation. In signs, you have LIO P2, a raised JVP, hepatomegaly, and peripheral edema. practical points are symptoms and signs often appear late and may be non-specific, because as you can see, this can be seen in various other conditions as well. So the early and late features, the early features are dyspnea, which is on exertion. So there is WHO functional classification. This is 1 to 4. Or WHO functional classification 1 means patient with PH but without resulting limitation in physical activity. Ordinary physical activity does not cause undue dyspnea and fatigue. In functional class 2, you have the pulmonary hypertension resulting in slight limitation. So they are overall comfortable at rest, but the ordinary physical activity causes undue dyspnea and fatigue. Next is 3, where it results in marked limitation. So they are still comfortable at rest, but even less than ordinary activity is causing problems. So this becomes a major issue. Finally, you have 4, where you are unable to undergo any activity without developing some symptoms, and patient can develop features even at rest. So this is how you describe the dyspnea on exertion, WHO functional class for the pulmonary hypertension. Next is fatigue and rapid exhaustion, dyspnea on bending forwards, that is bendopnea, palpitation, hemoptysis, exercise-induced abdominal distension and nausea, weight gain due to the fluid retention, and the syncope. In late, rare symptoms are the exertional chest pain, hoarseness, this is compression of the left laryngeal nerve which can cause these features, and finally you can have shortness of breath, wheezing, lower respiratory tract infections, and atelectasis. So the signs of pulmonary hypertension, as we have already described, are written over here. The signs have been described. The signs pointing towards underlying causes need to be seen. This is important. You need to look for digital clubbing, differential clubbing, auscultatory findings for lung and heart disease, sequelae for DVT, venous insufficiency, telangiectasia, looking for signs of connective tissue disorders. While you do all these things, do not forget to look for signs of right ventricular failure, that is peripheral cyanosis, dizziness, pallor, cold extremities, and prolonged capillary fill time. So the key investigations, once you see someone with these signs and symptoms, the first is ECG, which will show a right axis deviation and right ventricular hypertrophy, even arrhythmias. So normal ECG doesn't rule out a pulmonary hypertension, but if the ECG and the BNP are normal, then PH is unlikely. Chest X-ray can show enlarged right heart chambers, prominent pulmonary artery, and pruning of the lung vessels. Underlying heart and lung disease may also be detected. In pulmonary function test and ABG, you will find that it helps in differentiating pulmonary hypertension from lung diseases per se, from the other causes. Pulmonary arterial hypertension, the PFT is often normal and mildly abnormal, while the DLCO is reduced. In ABG, you will find low to normal PO2 while low PCO2. Severe hypoxemia may suggest other causes or shunts. Next, coming to specialized tests, the most common one has to be the echo, the first line non-invasive for all such disorders. It helps you estimate the right ventricular function. What you look for is tricuspid regurgitation velocity, right ventricular size and function, signs of left heart disease to differentiate from group 2. If you cannot confirm pulmonary hypertension alone, then the need for right heart catheterization arises. Ventilation perfusion scan can be done, which rules out and confirms the group 4. Normal scan virtually excludes group 4. These are the various echo tests that you can do. You can take a screenshot and see it later on. There are various tests to look for the pulmonary hypertension. Apart from this, there are other things as well to be seen in echo. That is, for in ventricle, you look for the RVLV basal diameter area, which has to be more than 1, flattening of the interventricular septum, TAPC by SPAP ratio. In pulmonary artery, you look at the RVOT-AT, early diastolic pulmonary regurgitation velocity, pulmonary artery diameter, vis-a-vis the aortic diameter. Inferior vena cava and the right atrium should also be looked in IVC diameter, right atrial area, and systolic. So this is an algorithm where you look for the peak tricuspid regurgitation velocity. Based on that, you classify uh, the presence of other echo signs of pulmonary hypertension shows what is the possibility. If the flow is low and the probability is low, then please start looking for alternative diagnosis. If the flow is between 29 to 3.4 and the probability of pH is intermediate, then also you look for follow-up. It is only when the flow is more than 3.4 and you have a high probability, you go for further evaluation. CTPA is another important thing that needs to be done. It will give you a idea about the lung condition. CTPA can identify chronic blood clots as well. Cardiac MRI assesses the size and function of the chambers, used in select cases, not in all cases. Blood tests like CBC, renal function, iron, thyroid, BNP, they help you rule out the alternatives. If you are searching from connective tissue disorders, you need to look for them as well as infectious causes. They help in finding the different other causes. Other tests like abdominal ultrasound, which will help you look for the liver diseases, which can be one of the causes. Cardiac pulmonary exercise testing, which is useful in unexplained exercise intolerance. And finally, you have some genetic tests as well, because some genes are linked with this. Next is right heart catheterization. It is the gold standard, directly measures the pressures and need for confirmation, especially before starting specific therapies. So a patient is suspected, you are doing your echo, then you need to go for right heart pressures to finalize your classification. These are the various pressures. I'm not going to details of this. You can take a screenshot and see them. Special tests, vasoreactivity testing identifies patients who respond to vasodilators, mainly the idiopathic and heritable pH. So these are the various routes through which these drugs are given. The half-life, the dosage, and the duration of action is given over here to look for the vasoreactivity. So in exercise and fluid challenge, it helps detect early diseases and helps differentiate the pulmonary hypertension types. So if it is idiopathic, then you need to differentiate them based on this vasoreactivity. So this is the diagnostic algorithm for patients who are presenting with exertional dyspnea and suspected of pulmonary hypertension. So first is take a good history, the physical examination, get an ECG done and get your BNP done and check for your saturations. In suspected cases, check for lung disease. These are the tests for lung disease. If you find the cause, then treat them accordingly. If no, then you need to do further workup. Find out risk factors for pH and the chronic thromboembolism. Look for cardiac. These are the other common thing. This is obviously you have to go for echo. If the probability remains high, then do the workup. If it is low, then you need to look for other causes. Now, if it is very severe with warning signs, then you directly go for invasive workups. So to summarize the presentation of these patients, clinical features in all the groups will essentially the same. This is the sex difference that you see in various age groups, in the various categories, oxygen requirement, the chest X-ray findings, pulmonary function tests, DLCO2 findings, ABG findings. So this basically helps you identify which group will show which kind of changes. So screening and early detection is important. Certain high risk groups should be screened regularly. Systemic sclerosis, they must go for annual screening using the multi-step algorithm. The patients with BMPR2 mutation should go yearly screening. Portal hypertension, especially if they're going for transplant. Post pulmonary embolism, symptomatic and persistent dyspnea should go screening. Screening is used for a combination of clinical, lab, imaging, and sometimes genetic testings as well. So now we focus ourselves entirely on the management of pulmonary hypertension group 1. We will cover it most of this in this particular lecture. next part, that is pulmonary hypertension with specific diseases. From there we will start in the next lecture. So the clinical characteristics is the symptoms are again non-specific and mainly due to progressive right ventricular dysfunction, modified by associated disease and the comorbidities. Severity is you use the WHO functional class, and history of the syncope, arrhythmias, hemoptysis. In physical examination, you look for tachypnea, tachycardia, JVP, echo findings we have already discussed, MRI, hemodynamics, exercise testing, biomarkers, they all need to be done as described before. So based on this, you do a classification whether the patient is at low risk, intermediate risk and high risk. Now this risk stratification, the 3-strata model, as I have described, then you also have a 4-strata model where you have the intermediate low and intermediate high. So the goal is to achieve and maintain the low risk status. For initial diagnosis, use as many variables as possible. However, at follow-up, focus on 3 main variables, but add an imaging and hemodynamic if possible. So this is the 4-stage classification. You can see the details of this. Now, what you do for treating these cases, the general measures are encourage supervised exercise after stabilization, anticoagulation not routinely recommended but may continue in idiopathic PH but avoid in systemic sclerosis. Diuretics for right heart failure and fluid overload, monitor the renal function and electrolytes. Oxygen, accept a PO2 less than 60, saturation less than 92. Cardiovascular diseases, treat with ACE inhibitors and SGLT2 inhibitors. Beta blockers not routinely used unless other comorbidities are present. Iron, correct the iron deficiency anemia. Vaccinations need to be done. Psychosocial support is required for the disability related with physical activity. Adherence, regular monitor and support adherence to the therapy. Special circumstances, pregnancy, the high maternal risk, avoid pregnancy if possible. Multidisciplinary management is required if the patient does get pregnant. Surgery, increase perioperative risk for them, and especially if it is done in an emergency procedure. Regarding travel and high altitude, oxygen is needed if they are going to very high sea levels, that is, they must at least avoid more than 1500 meters without any oxygen support. Specific therapies, calcium channel blockers only for the vasoreactive ones, reassess every 3 to 6 months. Endothelial receptor antagonists, the phosphodiesterase 5 inhibitors, guanylyl cyclase stimulators, do not combine these with the phosphodiesterase inhibitors. Prostacyclin analogs, which are both inhalation and oral, and the receptor agonist, which is given as a tablet. Treatment strategy is, if the patient is having no comorbidities, then low and intermediate risk, initial dual therapy, start with the ERA and the phosphodiesterase 5 inhibitors. For high risk, start triple therapy, that is these two plus IV or subcutaneous prostacyclin analogs. Add selexipag and switch to phosphodiesterase 1 to riociguat if intermediate low risk patient persists, means you cannot go down to low risk. Add an IV or subcutaneous prostacyclin analog and consider lung transplant if high risk persists. For patients who are having cardiopulmonary comorbidities, then start with a monotherapy with phosphodiesterase or ERA. Further escalation needs to be individualized. Combination is less well tolerated, so use any one agent and see which one best suits your patient. Drug interactions must be kept in mind because bosentan has important drug interactions with contraceptives, warfarin and sildenafil. Interventional therapies, balloon arterial septoplasty, post-shunt, these can be done in refractory cases. Pulmonary artery denervation is still in experimental stages. Advanced right heart failure, ICU management, focusing on treating the triggers, negative fluid balance, inotropes, vasopressors and avoid intubations if possible. And mechanical support with ECMO may be required. for a bridge to transplant, and obviously transplant is to be done in high risk and intermediate high risk. Immediate response to therapy is seen. Refractory pH is a indicator. High reveal risk score. Progressive disease. Most receive bilateral lung transplants. The complications are arrhythmias, major sinus rhythms are maintain sinus rhythm, which is important. Hemoptysis, mechanical complications like aneurysm, rupture, compression of the agents and structure. End of life care discussions need to be done. In case of advanced and risk cases, palliative support needs to be provided. Resuscitation decisions must be done very early. Drugs in advanced development, that is, we have ralinepag, which is a TGF beta pathway modulator and which has shown promise in the phase 3 trial. So if the patient is vasoreactive, then refer to a center. In there you do a right heart catheterization, see how the reactivity is happening. If more than 10 mm per Hg a drop in baseline is seen in the mean pulmonary artery pressure, or less than 40 with increased and unchanged cardiac output, initiate therapy with calcium channel blockers. That means this patient is a responder to the vasodilation therapy. Reassess it every 3 to 6 months. Check it with the BNP, the functional status, and with or add a hemodynamic if you want. Continue therapy and reassess every 6 to 12 months. Now, this is for patients with pulmonary hypertension who are vasoreactive negative. So the general measures throughout to be done: patients without cardiopulmonary comorbidities, as we have discussed, the management, you can see this written over here. So these are the various drugs that you can use, the various dosages. Thank you for your patience.